All right, is that better?
Yes, better.
Thank you. The Green Mountain Care Board's hearing of August 26, 2026 is called to order. We have an agenda today that includes an update on the AHS Healthcare Workforce Development Strategic Plan. Before we get to that, I will move to approve the minutes of July 15th.
Second.
All in favor, please say aye.
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 Aye. The minutes are approved. Second, the board has approved fiscal year 27 qualified health plan rate increases, and I will announce those pursuant to 8 VSA 4026E2. For Blue Cross Blue Shield of Vermont, in the individual market was 0.5%, and the Green Mountain Care Board approved a 2.2% rates. For Blue Cross Blue Shield of Vermont small group, the initial request from Blue Cross was 4.5%, and the Green Mountain Care Board approved 1.2%. The other carrier is MVP, and in the individual market, MVP initially requested 7.8% increase, and the Green Mountain Care Board approved a 3.9%. Likewise, MVP in small group requested 9.1%. That, I will turn it to Hillary Watson, our Project Director, Quality and Access at the Green Mountain Care Board, and Suzanne Tremblay, from the Director of Healthcare Workforce at AHS, for the GMCB staff presentation and an update. Thank you, Ms. Watson and Ms. Tremblay, for being here.
Wonderful. Thank you, Chair Foster and members of the board. Can folks hear me okay? And thank you, Ellie, for bringing up the slides.
I can hear you just fine. Thanks.
Wonderful. Thanks, Susan. Okay. Good morning. Happy first day of school or week of school for those of you navigating that transition. As Chair Foster mentioned, I'm Hillary Watson, Project Director for Quality Access and Planning on the policy team here at the board. Since it has been, a few weeks since we've discussed the Agency of Human Services Healthcare Workforce Development Strategic Plan, I just very quickly wanted to bring back around a few of the table setting slides that we have run through together in the past presentations, just to ground us in our review and where we are in this process. So next slide, please. Thanks, Ellie. So the first slide here is just a reminder of the guiding legislation. 18 VSA 9491 requires the Director of Healthcare Reform in the Agency of Human Services to maintain a current healthcare workforce development strategic plan. And then on the board side, 18 VSA 9375 details the duties of the board, one being to review and approve the healthcare workforce development strategic plan. Next slide, please. Perfect. So here, just for easy reference and access, we wanted to provide the links again to the Agency of Human Services Healthcare Workforce Development webpage. As we've mentioned before, AHS actively maintains this page, and it's where you can find the strategic plans as well as information about the advisory committee that works with the Director of Healthcare Workforce to develop and maintain the strategic plan. So I'll also note that as we discussed with AHS colleagues in our last meeting on July 15th, the Healthcare Workforce Strategic Plan Advisory Group did have their retreat on August 5th, and the agenda and meeting minutes have been posted to the website there if anyone wants to review those. Next slide, please. Thank you. So the last slide I have here is just an updated timeline. Given the very thorough and thoughtful public comment that we received last month and the great board discussion on the draft plan, the decision was ultimately made to postpone the vote in order to provide AHS with some additional time to incorporate the feedback and submit an updated updated version for the board's review. So without deviating too much from the content on this slide, I just wanted to briefly mention that while the details of that conversation live in the July 15th meeting recording, which can be found on our YouTube page, I just wanted to sort of highlight for everybody here that the main opportunity areas identified to strengthen the plan were really around including missing primary care and other provider perspectives, ensuring clarity or specificity around different types of workforce shortages, and then the corresponding strategies, to address those different challenges, and then adding implementation timelines, work plan details, responsible party, and monitoring information. So again, if you want to sort of dig into that great discussion, all that content is available for your review in the recording of the July 15th meeting. So then getting back to the timeline here as I wrap up, we've just added a few dates as we march toward that rescheduled potential vote on September 23rd. And I'll just note that today's meeting is an opportunity to hear an update from our colleagues at AHS, on discussions and work that's transpired since our last discussion last month. We don't anticipate receiving an updated version of the strategic plan until September 9th, which you can see on the slide here, at which point, we'll share that with the board and post that version to our website for public comment. So that's all I have for you this morning, and I'll turn it back to you, Chair Foster, to welcome those from AHS that are here with us today. Thank you.
Thank you for that walkthrough. Ms. Trumbull, I'll just turn to you. Thank you very much for being here and for entertaining the board's comments and questions and concerns and the public's, and thanks for providing us the update.
Absolutely. Thanks. I'm really happy to be here. I'm going to share my screen as I have some slides. Are you able to see my screen?
Yes.
All right, excellent. So I will get started. So good morning, everyone, and thank you for having us back. Happy to be here to share an update on the implementation planning the advisory group conducted on August 5th. And Hillary, thank you so much for the nice recap. I appreciate that and all the hard work you do. In that half-day retreat, in that session, we refined recommendations and an implementation structure for new projects, programs, and initiatives aligned with our strategic framework. We greatly, and I mean it, appreciated the public comments received from this last meeting we had with you all, and have incorporated both the committee's and the public's recommendations into the plan. Most notably, the profession-specific strategic roadmaps, beginning with primary care physicians. We also include a needs assessment approach and strategies to remove retention barriers and address wage disparity. We also recognize the need for a clear ongoing process for this committee and its public forum to provide us with input and receive updates. So without further ado, today we will show how Vermont's workforce strategy becomes a statewide healthcare workforce system, propose an annual cycle for input and updates, review current and ongoing workforce initiatives and momentum, and present some next stage projects for implementation, their timelines, responsible parties, and the like. The 2026-2028 plan is meant to move Vermont from a collection of initiatives, which we have a plethora of, to a coordinated workforce system. It presents a constant operating framework that organizes and guides Vermont's healthcare workforce actions. My goal is to codify this as the constant framework by which we operate. The framework consists of three major pillars, their associated sub-goals, and these pillars were identified and grounded in our foundation from the Strategic Plan Advisory Group through mission, vision, values, and charter construction. I want to formalize this into a healthcare workforce system with input and approval from this forum. The plan provides a framework and an operating cycle that turns data and stakeholder input into regularly updated priorities, guiding a statewide healthcare workforce system under this charter. There are no shortage of initiatives underway across the care continuum, across the state. The strategic framework that we're presenting gives us a consistent way to assess and implement both new and existing projects. As you can see here, there are many existing projects that we are keeping an eye on, tracking, and updating on a regular basis. Our initial gap analysis suggests that our greatest opportunity lies not merely in expanding programming, rather it lies in building a durable workforce infrastructure. And when I say that, I mean a durable cross-departmental, cross-agency, cross-sector, and cross-provider group workforce infrastructure. We have already begun operating under this structure. Our first pillar, Keep Vermont's Healthcare Workforce, is about retaining and operating and supporting the workforce we have. It organizes satisfaction, employee development, career ladders and lattices, workforce barriers such as housing, transportation, and wage disparities. Currently, we have a variety of programming that we are tracking to address the pillars priorities already currently underway through our rural health transformation programs, through activity throughout different departments within the Agency of Human Services, agencies beyond ours as well through the Vermont Department of Labor, and partnering organizations from around the state. Our second pillar, to build and grow the workforce Vermont needs, is about connecting education, employers, funding, and policy. It organizes demand relief, recruitment tools, and pathways to healthcare careers. There are a number of examples of this work already operating. We have our career and technical education centers throughout the state, public health and prevention initiatives, family residency programs, J1 waivers, e-consults, A-Scribe, A1 Scribe grants, telehealth technology, team-based care, scope of practice improvements, and those are just to name a few. Our third pillar is to know the workforce. We need to steer workforce actions from a place grounded in a shared view of need and impact. The state is currently advancing our data to become more accurate and predictive over time. What you will see in the next draft of the strategic plan will be the same structured framework and guiding principles. Added to that plan will be the new initiatives identified from public comment. Thank you for that. The advisory group that I connect with, the Green Mountain Care Board's recommendations, a variety of stakeholders from around the state, and providers from across the continuum of care. Added to the current portfolio of work, the plan is going to include an ongoing collection and regular reporting of workforce retention needs and initial workforce barrier recommendations, a standardized monitoring and evaluation framework for rural health transformation workforce projects with sustainability and scale recommendations included. It'll include a statewide inventory of workforce pipeline, pathway, and training programs with gaps and duplications identified and recommendations to streamline and align those activities. A communication strategy to attract, retain, and advance the healthcare workforce with emphasis on high priority professions. A feasibility and best practice report on establishing a centralized healthcare workforce learning and resource hub with regional satellites tailored to local regional needs. High priority profession specific strategic planning, beginning with a primary care physician recruitment and retention plan. We'll also conduct an inventory of others that exist, as we do know that there is a direct care workforce strategic plan and that the Department of Mental Health has one specific for our mental health professionals as well. There will be a coordinated statewide grants work group, data dashboards, and scheduled reports, and an integration of the Mini-Z single item burnout measure to help us measure retention and the reasons why folks are leaving the career, if they are, hopefully not. To recap, we're seeking your approval of the foundation and framework, the guide we'll use to align and evaluate all programs, projects, and efforts. The updated plan will be circulated by the 9th of September. In that plan, we have updated our initiatives, programs, efforts, partnerships. They include timelines, responsible parties, measurable outcomes, and public reporting. Other notable changes you will see will be profession-specific strategic planning, as I mentioned, with a primary care physician recruitment and retention plan led by the Primary Care Steering Committee. There will be a commitment to addressing provider retention, improved coordination with the Green Mountain Care Board. We seek your approval for the cyclical process we will follow. As you can see, we are here now in the decide, approve, adjust, or pause, because this cycle is ongoing. We have, as I mentioned, a variety of programming underway currently, and what we suggest is a cyclical process where we gain and gather and collect your recommendations, your suggestions, where we provide you with our progress updates on efforts underway. And I would expect maybe a June annual refresh and approval process. Approving this plan shifts us from siloed activities to a focused statewide workforce system with structural and organizational alignment to keep, build, and know our healthcare workforce. With that being said, I'll open it up for any comments folks may have. As I mentioned, we will circulate the updated plan by September 9th, and look forward to hearing from you all on that public comment during that public comment period. Ruth, I think you're first. Go ahead.
Hi, can you hear me?
I can now, yes.
And Chair Foster, is it okay if I ask a question?
Please go ahead, Senator.
Thank you. Well, Suzanne, thank you so much for the presentation. I'm wondering if if there will be any costs or funding sources mentioned in the plan, obviously to maintain and create a plan for workforce development and retention does cost money, and there are lots of funding streams out there, and I'm wondering if there will be any kind of recognition of those funding streams, and how much it would cost to maintain the plan. I especially ask because you mentioned physician recruitment and retention, and there's been some conversation by the board and others about the cost of physician education and how it's accounted for. So just wondering about the cost and funding sources. Thanks.
Thank you, Ruth. And I will say that this first go around, considering we have a variety of programming underway when it comes to physicians, when it comes to all of the professions across the continuum of care with the rural health transformation programs, a lot of the first year programming will be to identify any ongoing costs and where that money will come into play. So yes, but no, if that makes any sense. So it's really the setting the scene for identifying what funding sources, where they are. As I mentioned, we will look into a grant workforce group so that we are able to identify where the monies will begin to come from as we solidify the programmatic pieces of the plan. I hope that helps.
Okay, I think so a little bit. There are already a lot of funding sources available, and so having a collection, a table, or some kind of acknowledgement of what already exists would be really helpful, and that those go up and down the ladder from career and technical education to medical school, among many other funding sources. So having that kind of consolidated information about all of the funding available for workforce development, recruitment, retention, et cetera, would be really helpful to include in the plan.
That's fantastic. Thank you so much. I appreciate that, and honestly was looking through and started my own table just recently. So I appreciate that.
Excellent. Thank you.
You're welcome.
I'll turn to the board members. Why don't we start if Member Merman has any comments or questions, given that he is actually part of this workforce.
Oh, well, thank you. I think we're making, this has been helpful progress to see and additional information. I think one of the challenges that I have in this, I feel like, and maybe this is part of the process, is that I feel like we're getting to the point where we have a roadmap for, I think we're being asked to approve today is a roadmap for a plan. Now, the plan seems to be something that's going to take maybe appropriately time to develop what the needs are, what the measurements will be, and I think, as Senator Hardy just mentioned, sort of how to even fund this work and what the costs are and the various components of the workforce system. So I think there's this is clearly a big undertaking and requires a lot of thought and iteration on trying to figure out how to do this work the best. And I think this work is really important. But I think I still have a lot of sort of questions about, more specifics on what the needs for workforce are. And this, I think, dovetails a lot with the transformation work that AHS is doing. What measurements we're going to use to figure out if we're succeeding. I think you mentioned one of I didn't see it on the slide, and I don't have access to slides, but some sort of survey of maybe what I was wondering. It sounded like some sort of employee engagement type survey. So I think I'm still interested in learning more and understanding more about where we're going with this. And I think maybe this is part of the development of that process and how we're going to get to understanding the specifics of the issue and what the interventions are going to be and how we measure all of that. So thank you.
You know, I appreciate that, and I appreciate your recognition that it is a process and we're building a system at the moment to make certain that we are being held accountable for output. You know, in healthcare, I'm sure everyone here has heard this, you know, we're building the plane as we fly. This is an attempt at creating a system by which we're not creating the plane. We have the infrastructure in place to make decisions, to move forward, to have the data to come together on an annual basis and provide updates and progress reports to you all, and gather and garner information and feedback from you on where we should take things next. In the past, we've had, you know, a number of initiatives that we have launched. In the previous strategic plan, there were, I would say, 70 recommendations. And over the years, we have included those recommendations and created initiatives and programs and projects. This is a way for us to take that great work that we're doing, create a system for evaluating if those projects, programs, initiatives are working, and really focus our attention on the matter at hand. Healthcare is ever changing. At every moment, there's a new priority. So I'm feeling like creating this infrastructure is going to provide us with a nimble way in which that we can approach the ever-changing needs of healthcare in general. And I look forward to bringing more concrete implementation projects and programs and initiatives in the next iteration of the strategic plan, where you will see some more defined momentum. And I want to open it up to Julio, who is here today too, in the event that he would like to chime in. Julio is the Director of Healthcare Reform, and if he has anything to add to that.
Hey, this is Julio. Nice to see all of you. Yeah, just a lot of great feedback and commentary from everyone. Just another precise way for Senator Hardy for you to think about the question you asked us. Suzanne has done a really incredible job of building a cross-sector coalition across the continuum of care working on this plan, and has them all organized as part of an ongoing process. And as far as my understanding of it, they're currently doing all of that on a volunteer basis. So, in terms of the cost to keep this process going right now, by the grace of them giving us their time because they care about this work, it's not costing us anything. It's Suzanne really holding that strong cross-sector continuum of care coalition to bring this work output. And then just the other piece to really emphasize here is, what we're doing today is approving a structure for action and a framework that really is strengthening the work that is already underway. Just to really reemphasize again, there's 70 plus workforce initiatives going on across the state right now. And, what we're hoping for is, we're not waiting for a perfect strategic plan. We know that a strategic plan is always going to be a slice in time. But what we really want to do is organize the framework long-term around it, and really turn those 70 different workforce initiatives into something that becomes much more coordinated, much more measurable, and much more understood over time, so that we can continue to refine and change at the individual workforce initiative level, how all of this rolls up into that much bigger framework of, keeping our workforce and building our workforce and knowing our workforce. So those are just my quick comments on that. Thanks.
Thank you, Julio.
I think I appreciate the complexity of the process, and that process is really important, and this is necessary to ensure that we're doing the right thing. I would just say I have concern that that with an that the process may that the results and the outputs of this process may be delayed by an intent to getting the process optimized. And so there's workforce needs and there's complexity. And I know there's sounds like there's 70 different workforce plans and initiatives out there. I think that being someone who needs to approve a plan, I feel like we're talking again about a roadmap for a plan as opposed to the direct plan of what specifically we're, what are we measuring? What are our goals? What are we trying to do? And not just sort of how are we thinking about what are we measuring? How are we thinking about what are our goals? And how are we thinking about what we want to do? So I guess I still would I'm looking forward to the next plan iteration, which I think we'll probably have more specifics. Thank you.
I'll go in order today of Senator Hardy, do you have another comment or question?
If that's okay.
Please,
Thank you, Chair.
Make you an honorary board member today. Yeah.
I would love that. Thank you, Chair Foster.
We are taking applications, so maybe this is an audition.
Well, I don't know about that, but Julio, I just wanted to clarify what I was talking about for funding. I'm not talking about the funding to create the plan. I'm talking about the funding to implement the work that the plan is supposed to be planning for. And I agree wholeheartedly with Mr. Merman, who expressed concerns that there's so much attention to the complexity of the plan that it will never get finished and implemented. The implementation is the important part, not the plan. I mean, the plan is important, but if there's just a plan and no implementation, then what's the point? So the costs that I'm concerned about are the cost of actually recruiting, training, and keeping our workforce healthy and happy and successful for Vermonters to be able to get good health care. Thanks.
Thanks for that, Senator. Yes, we can definitely take that back and think through how to really, codify this moment in time where there are, 70 plus workforce initiatives underway, and then how we want to organize those under this structure. But again, none of those workforce initiatives are stopping pending approval of this plan. All of those are underway, and we want for all of those initiatives to not be siloed workforce initiatives or programs. We want them to all lead to a much larger outcome that I know everyone here in this group is passionate about. But yes, in the short term, we can take that back and think through how to really codify all of that work that's going on. But again, just really wanting to emphasize to the group that the work is going on. So thanks.
I'll go in terms of proximity of board member to practicing healthcare. So Member Walsh, that makes you next. And then Member Holmes, you're the only other one who can credibly use the term doctor in your title. So we'll go Walsh and then Dr. Holmes.
Thank you. And thank you, Suzanne, and thank you, Julio, for being here today and the work you're doing. I'd like to just riff on the airplane metaphor for a moment. It feels to me like you're building the shell of one, and that's where we're trying to get your hands around what we're doing. And what I heard from Dr. Merman was he'd like to see a flight plan, like where are we going, right? And what are the posts along the way? And if I could chime in on that, I'm interested in understanding the flight instruments. What are you looking at to know if you're staying where you want to stay, going where you want to go? And there's a whole host of things inside this complexity, but I'll limit my comments to just a couple things that I think are really important. We're trying to address a workforce issue because access in our state has been insufficient for a lot of Vermonters. And we're also trying to deal with an affordability issue at the same time. Workforce concerns, workforce shortage a felt shortage can be due to a numerical insufficiency or a structural throughput problem. Both feel on the end like an access problem. But distinguishing between a numeric shortage and a throughput problem is important, because simply adding more numbers on a throughput problem doesn't fix the throughput problem. And if we're trying to address affordability at the same time, healthcare is labor intensive, and labor is one of the highest costs. So adding more won't fix a throughput problem and will make affordability worse. So what I'm hoping to see in future plans is how we'll distinguish between numeric shortages and throughput shortages. And I understand that as a country, the US has a shortage of providers. But Vermont actually has a higher per capita number of primary care providers than almost every other state. Both of those things are true. The country has a shortage, so our numbers overall are lower, but relative to other states, we have a pretty healthy supply. That suggests to me that the problem is more throughput and care coordination. And how will we diagnose that, and how will we address that with our transformation plans? I think that's important because it affects not only access, but ultimately affects affordability. So those are my comments. Those are the things that I'll be looking for in the future. And I know that that's just a small piece of everything that you're trying to do. So thank you for the work that you're doing.
Appreciate that, board chair member. Yes, definitely we're not seeing workforce as simply a human resources issue. It's an access issue, a hospital stability issue, a rural economic development issue, and ultimately an issue of whether communities receive care close to home and how that looks like. Yes, and to riff on your airplane analogy, I think we're trying to create an air traffic control tower while at the same time helping 70 plus different airplanes organize either as separate airlines or their landing order. And then hopefully in the future, build a much more precise airline or fleet of airplanes for what we're trying to do. So thanks for your comments.
I see what you did there, and it was nicely done.
It's funny because as I was going through my notes, I started with riffing on it myself, and I went down that same rabbit hole, Julio.
Thanks.
Lots of riffing. I love the riffing. I love airplane, air traffic control analogies. And definitely, Chair Foster, no doctoring from me at all. You do not want me to do that. I just want to say, first of all, sincere appreciation, for hearing our feedback after the last meeting and, taking that into consideration. It sounds like the retreat was productive and helpful, and really appreciate the emphasis on primary care and really thinking about that. And also the implementation and monitoring, really thinking hard about that, because I think that's an area where accountability is really key. And if we have a strong implementation plan and a monitoring plan and transparency around that, obviously there's more likely to be success. Which, I guess, my first question is and this is really a rhetorical question, but I recognize that this work is going to take time. And I guess the rhetorical question is, do we actually have time? The reality is we're seeing retention issues. We're seeing, baby boomers retiring. We know all the forces, and the question is, do we actually have the time? But that's more of a rhetorical question. I think that what I'm going to be looking for really is, and this is part of the air traffic control tower that you're describing, is really understanding how this plan, this roadmap, is going to map with the rural health transformation funds, right? We've got $200 million coming into the state potentially if allocated well, and we continue to get that funding. How does this map to those resource allocations and the RFPs that are going out, and then also the simultaneous work of the hospital transformation work as that is happening, and we know that there may be service line movement, and we know that there may be changes happening within our hospital systems if we're moving towards centers of excellence and really thinking about, pushing care out into the community and all the things that we say that we're doing with rural hospital transformation work. There's going to be need for redeployment and coordination of those providers and those clinicians rather than having them, leave the state. How do we retain them as we're thinking about reimagining our hospital systems? So I will be looking for how does that all map, and how are we ensuring that air traffic control is actually happening, given the resources that are coming into the state, and also given the hard work that has to be done to think about hospital sustainability and the delivery of care and ensuring that essential services are retained in each community. There's a lot going on at a very large organization, and how is it all talking to each other, connecting with one each other, and moving in the same direction? And so that, you've spoken to it, but those are things that I really hope are clear in that roadmap. But appreciate all the time. I don't have any specific questions. Thank you.
I remember teacher. I don't know if it's you or me, but we'll go to you first.
Okay, mine's very quick. I just wanted to say I thank you for being responsive to the discussion at our last meeting on this topic and to the public comments. I really appreciated that. It appears from the presentation you just gave that you're, considering those and including those suggestions in the next draft on September 8th. So I will be looking for that in the next draft. So thank you.
Just a couple. Developing this strategic plan, if you could describe the interaction and input you've had with the Larner School of Medicine.
So the area health education centers are present at every advisory committee meeting. So they're a part and parcel of creating this strategic plan. And not just the Larner College, but also the additional area health education centers from around the state.
And what input did Larner have on the plan?
What specifically?
Yes.
Oh, I don't know that I could say that because that's work group information. You know what I mean? Like that I provide work groups and the output comes from, a variety of folks communicating with one another and providing it as a group. So it's kind of hard to say specifically,
Okay.
if that makes
Right.
sense.
I mean, kind of. I mean, I guess the question is maybe offline you can advise me like where I can go to see the output from the work with that work group that included Larner. And part of the reason I ask is because we have authorities relating to our budget process, relating to education and development of physicians as well. And so I wanted to understand what Larner's view was in connection with this plan and how you're thinking about their plan or their input and whether or not you think it meets our state's needs.
I was provided with the preliminary plan recently, and that will be, as we continue to work through the final draft considered. They're at the table at every meeting, and a part of creating this work. And if you go to the website, all of our past meeting minutes and notes and presentations are there.
Has there been discussion of how many physicians Larner is producing in its graduating class that are staying in Vermont?
I can't say for sure that I could tell you the number, but yes, it has come across conversation.
And just given your role, I definitely appreciate any input and suggestion you have for us at the board. So I'm having a bandwidth issue. Are there any an initiative?
Sorry, Chair Foster, but you've cut out.
Seem to have a bandwidth issue today. I turned off my camera for a moment, which should help. Is that better?
It is.
Okay. The CARE Board has responsibilities and authorities relating to workforce development as well. And I was asking if there's any input you have for what we should be looking at and considering when we review hospital budgets in connection with our workforce charges.
That's
Stated
a good
another way,
question.
is there anything you think that we should be doing? From your perspective, is there anything that you think we should be doing?
That's a good question and something I would definitely take back with me and not answer in the moment. Just
Great.
to think about that. Thank you.
No, fair enough. Thank you. Okay. I'll turn it to public comment via raise the hand. Chair Black.
Sorry, takes a minute to unmute a little bit. Thank you for your presentation and the follow-up to your original presentation. I think I wanted to also, Julio, nice to meet you virtually because we haven't met yet. I think we've been throwing around a lot of metaphors today, and I guess my question is, and I feel as though we've been working on workforce challenges for as long as I've been in state government trying to affect workforce. And I'm worried that we're creating a roadmap and we haven't even really figured out where we're going. And I also, a part of me thinks, would we have the same outcomes if we did nothing at all? Because I can tell you, we have put a lot of resources towards workforce, specifically in healthcare. And I'm wondering if we had just left it alone, frankly, if the market would have done just as well of a job as what we currently have. I listened intently to all the hospital budget hearings, and several of the hospitals of their own volition are working on workforce and upscaling their workforce, using their workforce in different ways. That's another thing that I look at this strategic plan and I think to myself, are we creating a workforce? Are we driving towards creating a workforce for a system of care that we want, that we currently have? And why are we not asking the question, how can we change the system, the future system of healthcare in the state to meet the realities of what we have for workforce? And I feel like that conversation gets lost a little bit when we talk about workforce challenges. Are we driving towards something because that's what we want, the system of care we want? Or should we be tailoring the system of care that we want to the actual workforce that we have? And that is one piece that I don't see in a lot of the strategic plans is how are we thinking about how we deliver care differently so that we can take advantage of what we actually do have. Anyways, again, thank you for your presentation, and I look forward to continuing this conversation because I know this conversation will continue. Thank you.
Absolutely. And may I respond briefly? I would like to make mention of a couple of things. And you ask, would it have made a difference? Specifically, the Vermont Talent Pipeline Management System and pipeline programs for nursing students or for nurses has impacted costs dramatically, reducing the number of traveling nurses. And that is one of those programs we have recognized has success and would like to identify to scale. When thinking about working with what we have, we know that we have an aging population. We know that our baby boomers are heading out and leaving, and our Department of Aging and Independent Living has a fantastic strategic roadmap for direct care workforce and direct care workforce development underway. And a lot of what we're talking about here is there are great minds and great work happening in all around Vermont. 50 initiatives within the state, 70 plus with our partners around the state. It's about time we take a look at that information that we're gathering from those programs and identify and scale what is working and what is saving us money. And as I mentioned, there's work underway that is advocating for and growing our direct care workforce is going to take care of an aging population and home services. So what you've discussed is exactly where we'd like to take this work, and I appreciate that.
Thank you for highlighting that. Thank you for your response. You had spoken in your presentation about how we support the workforce that we currently have so that they can maintain. And you talked about like direct care services. Talked about work with designated agencies. I'm concerned that oftentimes we don't support. We say we support our workforce, but are we putting our money where our mouth is? Is the administration advocating for increases to our designated agencies every single year? Are we increasing Medicaid rates for services that are vital and actually do save money? So yeah, what are we doing everything we can to support the workforce that we currently have? Thank you.
Very nice to meet you, Madam Chair, and look forward to talking with you in more detail about all these things. And yeah, noting from Chair Foster, there might be a process opportunity for how some of this work integrates into hospitals' annual processes and what they self-identify for workforce. But I think bigger picture, what the Madam Chair is talking about is, things that we don't normally think about workforce enabling that we are investing in, things like telehealth or e-consults or remote patient monitoring. I don't know, we have to really think about this at a much bigger picture. And like Madam Chair is saying, think about not only keeping the workforce of today, but thinking about that workforce of tomorrow. And so some of that work is going, and looking forward to figuring out how we highlight that in this plan, but then in more detail, brief others. So thanks.
Thank you. Walter?
Thanks, Owen. I'd like to address some comments by Senator Hardy and Representative Black, which I think they kind of nailed it. One is about the implementation. We hear stuff all the time. We have studies galore about all this and that, and nothing's ever done. And Representative Black made the comment about, are we helping our current workforce? And as someone who is 71 years old and still in the workforce, as a wage earner, commonly called a wage slave, I wonder whatever happened to that old adage of you pay people right and you treat them right. You can have all the plans you want, and I know this from experience because I've been in the workforce for 57 years. All the carrots and the sticks and so on and so forth, but if you don't pay them right and you don't treat them right, you ain't getting anybody. I don't care what studies you do. I'm in the tourist business, which is not that much different than the healthcare field in many ways, and it's the same thing that's going on in both areas. Working people are treated as resources, not as assets. They've done away with retirements and everything. So if you don't pay them right, you don't treat them right, you're not getting them.
Thank you, Walter. Representative White?
Yes, hello. Thank you, Chair Foster. Can you all hear me? I'll keep my video off in hopes that you
Yes.
can hear what I'm saying. Thank you. So I appreciate the presentation. I just had a couple comments. First of all, a lot of talk about primary care and our need for more primary care physicians in the state. And I just want to emphasize, I think we did pass some legislation this past session that would prevent cuts to primary care like have happened in the past, particularly in my district where UVM closed our primary care facility in Waitsfield. And so recent legislation, I think, has changed that so it can't happen without a public process and without Green Mountain Care Board trying to intervene. But I just want to underscore that, all this talk of growing our workforce, and we've really got to make sure we're not losing more primary care in the state. So I think we've done some good there, but just it's so essential. And then the other thing I wanted to comment on, which is related, is I appreciate Chair Foster just bringing up Lerner School of Medicine. And as we talk about real shortages in providers around the state, I don't have the background in terms of like what the federal government is financing for medical school. But if we've got all these doctors graduating from medical school at the University of Vermont, is there a way we can, are we doing everything we can to keep those providers in the state, incentivize them to stay in the state, doctors, nurses, et cetera? Because I think they are receiving something, and want to make sure that we are keeping them here while we can. So thank you.
Thank you, Representative White. Ms. Aronoff?
Hi, good morning, everyone. My name is Susan Aronoff. I do the policy work for the Vermont Developmental Disabilities Council. I'm a state employee housed in the Agency of Human Services, but we are entirely federally funded. In exchange for the state of Vermont to receive that federal funding that pays my salary, we have a memorandum of understanding that makes me free to speak and advocate or question positions of the Agency of Human Services. So I speak on behalf of people with disabilities and their family members, specifically people with intellectual and developmental disabilities. The people I'm most concerned about and that my questions pertain to or my comments pertain to are the people who have jumped through all the hoops and have been found eligible to receive Medicaid-funded home and community-based services for their disability. And those people might be seniors, elders, people with physical disabilities who receive their services through Choices for Care. So in some states, someone with cerebral palsy would be considered a person with a developmental disability. But in Vermont, someone with CP would most likely receive their services under Choices for Care as someone with a physical disability. Someone with Down syndrome might be receiving their services through the Department of Disabilities, Aging, and Independent Living Developmental Services Program. I say all this because our home and community-based care workforce is spread out between our home health agencies that serve people in Choices for Care and our designated and specialized services agencies that serve people with developmental disabilities and children who get special education services or medically high-tech care needs, Success Before 6, etc. And really my question and comment is I agree with a lot of what Chair Black and Senator Harvey said about what are we really doing here? And I think that Member Walsh's questions about how are we measuring success are so critical. So my comment for the healthcare workforce is, after Oliver Wyman, I was optimistic that people were going to recognize the value of a strong home and community-based service system necessary for discharging people from the hospital, keeping people out of the hospital. The current rate for developmental services alone is that of the services that we are paying for with Medicaid, only about 55% of those services hours are able to be delivered by our specialized and designated agencies. That's 55% of the hours someone needs or gets for community support. Our total statewide service delivery rate, last time it was measured for developmental services, is 55%. And that's because of the workforce shortage. So my question really is, are you measuring the impact of that Dale campaign you referred to in the answer for the community health workers? If so, or is it having any impact? Because the designated agency report that's cited in the workforce report showed in 2025 like a 20% vacancy in the DS developmental services program alone. And I just want to know, are we at 18%, 17%? Can you tell me any good news on the direction that we're moving in? And we got to move faster. So we've got to get those rates up so that someone can have a career in keeping people safe at home where everyone wants to be, to age in place, to get their services out of expensive ERs, out of expensive hospitals. We've got to get those wages up. Thank you. That's my main comment.
Thank you, Ms. Aronoff. Mr. Fisher?
Good morning still. Good morning, everyone. Mike Fisher, healthcare advocate. I am going to be brief because I'm looking forward to the next subject. So I think I just have two comments, not really asking for a response. First, I also appreciate the focus on primary care, but wow, specialty care wait times is a major stressor for people calling our office. Cannot be forgotten. And second, maybe this goes a little bit in line with a bit of a different flavor on it to what Chair Black was saying. The landscape is changing under our feet. And any planning effort that doesn't contemplate predicted changes, here I'm talking about loss of coverage. We're losing people from who's covered right now. We have lost, and we're losing a bunch more on October 1st. We're going to lose more after January. You know, how do we make sure the basic question is, how do we make sure Vermonters can get the care they need? And so I sure hope that this planning effort, like all planning efforts, contemplates what we know is coming at us and builds those contemplations into any plan. Thank you.
Thank you, Mr. Fisher. I had one kind of other question popped in my head as we talked about this and we had public comment. So if you look at the physician census data that we have, it has not been strong the last decade or even 2 decades. I know that reflects to some degree national trends. And if you look at primary care provider numbers and even physician numbers as a whole, it hasn't gone as we would like if we actually had a strategic plan at the time. Has it look back retro and how this plan will arrest and change that issue?
Chair Foster, it cut out in the middle of your question. Apologies. The last part we got was you were talking about the physician census data and contextualizing it for Vermont, and then it cut out.
Sorry, that was the best part too. I'm having bandwidth problems today. My question was, has there been a look back at where the state didn't achieve over the last 10 or 20 years in recruitment, retention, and development of practitioners? And have we incorporated that thinking in terms of why and how we failed historically into this plan?
I will say that with the consideration of profession-specific roadmaps, that would be at the forefront of creating that profession-specific strategic plan for primary care physicians. We do have some data that we are able to go back to that has been collected and reported on through VDH and Larner College and the AHEX on some of the programming that we have been providing over the past years since, I would say, 2010. Retention rates for loan repayment and such, and some work that VDH has done on surveying and researching on that. So those would be formidable and as a way to move forward with planning specific profession.
Okay, thank you. Walter, your hand is up. I don't know if it's still up or if you have another comment.
Somehow it got up. I thought I lowered it. So it should be lowered.
Okay. All right.
Thanks, Owen.
Okay. I see no other public comment. Mr. Cespedes and Ms. Tremblay, thank you very much. We will take a 5-minute recess and we'll come back to have an update on reference-based pricing. So we'll be back in 5 minutes. Thank you.
Thank you all.
All right, we will resume our hearing of August 26th. I will turn it to Elena Barabee, our policy director, who is going to provide an overview of the state's reference-based pricing initiative. Huge thanks and kudos to the team and Ms. Barabee for the leadership. This is a massive project. It's extremely innovative, and it's the only state in the country that's taking this on for the entirety of the commercial market. So I think we should really appreciate how hard people are working and what this means for the state. And I'm extremely excited for this update. So Ms. Barabee, I'll turn it to you and thank you and your team for this.
Great. Thank you, Chair Foster. I just want to take a moment before we get started to acknowledge this important work stream as kind of one program and a suite of tools across our portfolio of affordability strategies. We know that hospital prices are a key driver of healthcare spending and premiums, and Vermonters are feeling this acutely. So despite significant progress in recent years, Vermont continues to have some of the highest health insurance premiums in the country, and our hospital prices are a significant part of that story. So there's still significant work to do. Reference-based pricing is one tool that can help address the driver directly by setting limits on what Vermonters can be asked to pay for hospital services to a defensible, transparent benchmark rather than allowing prices to rise arbitrarily. I want to be clear, though, from the outset, this is not a silver bullet. It's not meant to stand alone or solve all of our healthcare problems. It's one piece of a broader affordability strategy, and its success will depend on how well it's designed, how well it works alongside other efforts, including those of our partners at the Agency of Human Services, the Department of Financial Regulation, and of course, decisions made by our payers and providers and many other stakeholders who play a part in improving our healthcare system. As we dig deeper to discuss our approach today, our goal is to get this right, to build a program that is sound, sustainable, and actually improves affordability so that all Vermonters have access to healthcare they need when and where they need it. This means being deliberate about design choices, learning from other states' experiences, and staying grounded in the data on what's actually driving costs here in Vermont. With that context, I'll turn it over to Kirk and Olivia to walk us through the details of this work to date and what you can expect next. Thank you.
Thank you, Elena. Good morning, everyone. I'm Olivia Mitchell, a senior policy analyst at the Green Mountain Care Board, and this is our agenda for today. So the first half of the presentation will focus on the reference-based pricing work that the board has undertaken since the passage of Act 68 and our conceptual framework for reference-based pricing rule. And then the second half of the presentation will be a bit more forward-looking and will include a brief introduction of RAND and Baylor Health, experts who the board have contracted with to support Vermont's reference-based pricing implementation. We'll provide a high-level overview of their planned work, and then we will close the presentation with a preview of upcoming opportunities for stakeholder engagement and future reference-based pricing progress updates. So we wanted to start by providing a brief overview of Act 68 just to remind folks of the legislative basis behind Vermont's transition to reference-based pricing. Act 68 was enacted by the Vermont General Assembly in 2025 to achieve transformation and structural changes to Vermont's healthcare system. And Act 68 includes a number of different components and initiatives to improve care and contain healthcare costs, among them reference-based pricing. Act 68 directed the board to begin implementing reference-based pricing for Vermont hospitals as soon as practicable, but no later than hospital fiscal year 27. And here in Act 68, reference-based prices are defined as the maximum amounts that Vermont hospitals shall accept. And we want to take a moment to acknowledge that both the Green Mountain Care Board and the legislature recognize that this was an ambitious timeline, but Vermonters were and continue to face real affordability pressures that require prompt but thoughtful action and meaningful change. So the Green Mountain Care Board sought additional legislative support to meet this timeline, which we will discuss in further detail in a moment. And this slide just kind of provides an overview of some of the key requirements for the board in the context of reference-based pricing under Act 68. But we'll go to the next slide where we provided a summary of really 4 main buckets of reference-based pricing activities for the board under Act 68. So the first is to establish reference-based pricing for hospital services by FY27. The second is to review and monitor reference-based pricing annually as part of our hospital budget review process, and also as part of monitoring, we're charged with working with DFR to ensure that reference-based prices results in decreases to health insurance premiums for Vermonters. The third is to identify conditions for modifications or termination of reference-based pricing, such as reductions in quality or access. And then the kind of fourth component is that the board may expand reference-based pricing to non-hospital services such as primary care. So before we really get into the work that the board has undertaken to support reference-based pricing since the passage of Act 68, we felt it was also important to remind folks what reference-based pricing does and does not do and how it contributes to healthcare payment and delivery reform. So at its core, reference-based pricing establishes a price cap that is keyed to a publicly known benchmark, such as Medicare. And Medicare is a common benchmark that many other states with reference-based pricing programs use. And one reason why they use it and why it's so common is because Medicare rates are determined at the federal level and are based on cost data that is submitted by hospitals. And by establishing a price cap that is more closely related to the actual cost of providing care, reference-based pricing limits hospitals' ability to set prices higher than necessary, protecting patient affordability and reducing price variation for Vermonters. And when we talk about reducing price variation, we can think about this in two ways. The first is reducing unjustified price variation or differences in prices across hospitals for the same or similar services, meaning the price of an X-ray at one hospital doesn't differ substantially from the price of receiving an X-ray at another hospital. And the second way we can think about how reference-based pricing can reduce price variation is by serving as a mechanism for really recalibrating prices. So addressing both excessive prices relative to Medicare, where Vermonters pay more than necessary at the point of care, and addressing services that are historically underpriced. And then the thread throughout all of this is transparency. So under reference-based pricing, hospital commercial prices are expressed as a percentage of a common benchmark, allowing for a more apples-to-apples comparison across hospitals, and hospital prices are capped at a number that is publicly known. So this contributes to a transparent and systemic payment and delivery reform. And with that, it's also important to remind us of what reference-based pricing does not do. So while reference-based pricing establishes a maximum amount that Vermont hospitals shall accept, it does not set prices across the system. Hospitals and insurers can still negotiate prices below the price cap. Additionally, reference-based pricing primarily targets prices, but total health spending is a function of both prices and utilization, or the volume of services, so it does not alone control total hospital spending. It also does not guarantee savings, nor that they are passed to consumers unless specified. But as mentioned, Act 68 does direct the Green Mountain Care Board to ensure that reference-based pricing decreases premiums, and this will continue to be a goal during program design and rulemaking. Also, as mentioned earlier, reference-based pricing can be used to recalibrate prices, bringing both those higher price services relative to Medicare down while potentially bringing underfunded services up. But this requires additional specified design elements and restructuring incentives around prevention and care delivery, likely would require additional more significant lifts, such as a primary care pool. And while reference-based pricing seeks to contain costs and lower average commercial prices, low prices are not in and of themselves markers of efficiency, nor do reference-based prices necessarily target quality performance. So this requires additional guardrails or incentives to maintain and improve quality, and promoting hospital efficiency, particularly in revenue-constrained environments under a reference-based pricing model, will require increased focus on operating expenses and admin costs. So now that we have kind of refreshed ourselves on why Vermont is implementing reference-based pricing and the critical role that the program will serve in protecting patient affordability, we want to highlight the work that the board has undertaken since the passage of Act 68. In the time since its passage, the board has been steadily building the evidence base, technical capacity, and the regulatory architecture that a durable reference-based pricing program requires. So the first kind of primary task that we worked on was establishing what Vermont hospital prices actually are. So the board partnered with various experts and met with stakeholders to establish a baseline understanding of where Vermont hospital commercial prices stand today compared to their Medicare equivalent payments, which we will explore in further detail in a moment. And the second primary bucket of work was securing outside analytic and implementation support to ensure that Vermont's reference-based pricing program remains rooted in rigorous analysis and evidence, and that the implementation receives the dedicated expertise and staff time that it requires. And as noted at the top of the presentation, we'll provide additional detail on the board's competitive procurement process and the selected contractor in the second half of the presentation. And then the third main bucket that we've been working on was seeking the legislative support needed to meet Act 68's ambitious timeline. So the board requested implementation assistance from the General Assembly, which morphed into S190, which my colleague Kirk will go into further detail on later in the presentation. So here's just a timeline and a bit of a more detailed overview of some of the board's key reference-based pricing related activities to date. And as you can see, the board began mobilizing on reference-based pricing in the fall of 2025, following the passage of Act 68. And just want to note that building the evidence base and technical capacity for a program implementation of this manner is not always a fast or simple process, but it is a necessary process to ensure a really solid foundation and durability for Vermont's reference-based pricing program. So now that we've provided an overview of some of the initial planning and evidence gathering that the Green Mountain Care Board has conducted in preparation for reference-based pricing, we'd like to share some of the key observations that we've learned from this work and some of the takeaways that have and continue to inform our implementation approach. So I think anyone who has been tuning into presentations has seen this slide before, but tough to kind of overemphasize. Market concentration describes how much control a few hospital systems hold within a given area. And according to the Federal Trade Commission and the Department of Justice, markets with an Herfindahl-Hirschman Index, or HHI, above 1,800 are considered highly concentrated. And this is a level that is often associated with higher prices and fewer choices for consumers. So in 2025, the average hospital HHI was 5,467, and in Vermont, the average HHI was 7,608. So Vermont is at some of the highest levels of market concentration with little to no competition. And in hospital markets that are effective monopolies and have such high concentration, regulation isn't a departure from sound economics, but it's often the only tool left. So that is just some of the basis for why it is so important for us to be implementing reference-based pricing. And then indeed, we see that across Vermont's hospitals, average commercial prices are frequently many multiples of Medicare. So as part of building up our evidence base, we partnered with OnPoint to analyze Vermont's hospital commercial prices and issued a new release of our price transparency dashboard that includes calendar year 2025 data, which is the most recent year available. And in 2025, the average commercial prices as a percentage of Medicare at Vermont hospitals were in the range of 450% of Medicare. And on average, commercial prices, again, expressed as a percentage of Medicare, were higher in the outpatient setting. So at around 503% of Medicare for outpatient services and 333% for inpatient services. And then also just want to note that prices vary widely across hospitals for this same or similar services with no discernible relationship to quality to explain these differences in price. And then just for comparison, Vermont's hospital commercial prices relative to Medicare were the 14th highest in the country in 2022, according to the RAND Hospital Price Transparency Study. And just want to note that defining a Medicare payment for a service is complex and it can be defined in different ways depending on how the base payment and add-ons and adjustments are considered. So RAND uses a slightly different methodology than the Green Mountain Care Board does in our price transparency tool. So you might notice that the prices as expressed as a percent of Medicare might differ between these two resources. However, RAND's study allows these comparisons across states and was really foundational for our initial understanding of Vermont hospital prices and catalyzed this further action that you're seeing. And so when we break this down by inpatient and outpatient services, we see that Vermont's higher average commercial prices relative to other states are largely driven by above average outpatient prices. And I know this chart is a little hard to see, but those outpatient prices are shown in those green squares, and we have Vermont highlighted in green there as well. And then average commercial inpatient prices in Vermont are actually below the national median, and that's shown by those blue circles. So kind of digging into those outpatient prices at the service category and subcategory level using our price transparency tool, we see that there are various outpatient outlier prices that exceed 500% of Medicare. And some of the highest price outliers, as you can see here, again, as a percentage of Medicare, in Vermont were imaging, labs, and injections and infusions. And we also want to note that these are often outliers when compared to costs as well. So hospital costs are significantly lower in outpatient settings, as inpatient care is usually more time, labor, and equipment intensive. However, in contrast, there are some hospital services that are lower priced relative to Medicare, and a disproportionately low share of healthcare dollars go towards primary care in Vermont. And aligning with the definition of essential services used to inform notice of service reduction policy under Act 146, we've seen evidence suggesting that these essential services, such as obstetrics, perinatal care, and inpatient psychiatric care, may have been historically underpriced in Vermont. And this leads to some really difficult choices for hospitals, and these services are often the first ones to be cut. And this is something that we are continually monitoring, analyzing, and keeping in mind as we work through our reference-based pricing design. And I will now pass it on to my colleague Kirk, who will walk us through findings from an analysis of Vermont's Medicare payments.
Wonderful. Thank you, Olivia. Great job laying all of that out. Hi, everybody. I'm Kirk Williamson, and I am the Project Director of Affordability and Pricing on the policy team here at the board. So during the legislative process and then continuing after the passage of Act 68, there was a lot of misunderstanding about Medicare payments, current commercial prices, and what is meant by a Medicare price. There was a pervasive narrative that Vermont hospitals were the lowest paid by Medicare in the country, which would have clear implications for a reference-based pricing program that capped prices as a percentage of a Medicare equivalent payment. So to help answer that question, we partnered with economists at Brown University to better understand Vermont's Medicare payment landscape and reimbursement trends, which illuminated several key findings that are foundational to how we think about the reference-based pricing program. So first, Medicare payments to Vermont PPS hospitals are above the national average for a standardized case. Second, a large portion of final Medicare payments to Vermont PPS hospitals is driven by receiving more in add-on payments than hospitals in other states, particularly hospital-specific payments. So hospital-specific payments are reflective of what is known as the sole community hospital designation. That designation pays hospitals the greater of either the standard DRG rate or the hospital's own historical cost-based year rate, which is updated for inflation. So instead of receiving the standard payment rate in that given year, the hospital gets paid at its typically higher hospital-specific rate. So that cost-based year could be 1982, 1987, 1996, or 2006. And all of that varies by each hospital. So each PPS hospital that has a sole community hospital designation could have a different year that I just mentioned. So in this way, it's really important to separate reimbursement or final payments from what is a prospective price. Hospitals could perform more complex cases. They could gain or maintain a hospital designation, which serves to increase payments and revenues. And then conversely, they could lose a designation. They could perform fewer complex cases. They could have a less favorable payer mix or have more transfers or higher readmissions, which all serves to reduce their payments. But we're really focusing on prices for similar services across hospitals for the purposes of this reference-based pricing program and for today's discussion. Next slide, please. So the third finding is that the range of Medicare-based payments plus add-ons and adjustments across Vermont hospitals, at least PPS hospitals, is really similar to the range of Medicare payments made in hospitals in neighboring states like Maine and New Hampshire. And so when we talk, or you hear us talk about the adjusted Medicare base rate, there are a few reasons why we exclude policy add-ons. Not only does it create an uneven playing field, it's all of those colors that are not blue, Not only does it create an uneven playing field, but it's really challenging to know these designations or these payments prospectively. We also don't necessarily want to import federal policy decisions into Vermont carte blanche. Next slide, please. And finally, using adjusted Medicare base rates for reference-based pricing creates more price consistency across hospitals and for Vermonters. Our use of adjusted Medicare base rate as the reference price is intended to create more predictability than in other states like Oregon or Washington, which set a reference-based pricing cap at 200% of the Medicare final payments. Our work with Brown found that it would be roughly equivalent to 275% of the adjusted Medicare base rate, which would be the 200% Medicare final rate. It also creates a standardized approach for critical access hospitals. And as many of you, at least on the board, know, critical access hospitals are reimbursed differently than PPS hospitals by Medicare. They are reimbursed at 101% of their costs. Next slide, please. So to spend just a little bit of time on S190, so as Olivia mentioned, we knew that this was an ambitious timeline in Act 68 to implement reference-based pricing by FY27. We knew we couldn't have a rule in place in that time, so we went to the legislature and we developed a proposal that morphed into S190. It contemplated a phased implementation that would have began with the qualified health plan market, so the ACA marketplace, and for VHI, which represents the teachers, in 2027. That legislation passed both chambers, but it was vetoed by the governor. The governor's stated preference was to apply the reference-based price to the entire commercial market and ensure that those savings are not concentrated, but diffuse, so not concentrated at any specific group. But then the governor's office issued an executive order doubling down on reference-based pricing and providing a lot of weight for the Green Mountain Care Board to move forward. And so, much of the work that went into S190 over the months at the tables with Madam Chair Black and with all the others and stakeholders too, it really does help to serve and inform our reference-based pricing implementation. And so several core elements do carry forward, like the definition of the Medicare adjusted base rate, using the Medicare prospective payment system, or those rates as a reference for critical access hospitals. There was a lot of work that went on negotiating what went into that package, but where there was controversy was around targeting the qualified health plan market and VHI. The reason that we chose, or the legislature chose, to go with the QHP market and VHI is because of the precarious nature of the ACA marketplace. We know of the loss of enhanced federal subsidies. We know about the challenge of many Vermonters in choosing plans that help them access care. And then we also know that with VHI, that is tied to our property taxes, and we know we have an issue when it comes to property taxes. So the savings were concentrated in those two markets to help shore them up and to help lower or give relief on property taxes. However, that was vetoed. So again, the definitions, the approach, all of that makes sense. Right now, we're really focused on the cadence and building on this framework. So we really want to build on the debate that was had in the legislature and really take the things that weren't up for debate and move that forward. So next slide, please. And just to round us out, before I turn it over to our legal team that will walk you all through the reference-based pricing rulemaking process, I do want to highlight a few key takeaways and lessons learned from these initial months of analytic work and implementation planning. First and foremost, that high hospital prices are a key driver of high healthcare costs here in Vermont. In the long term, prices need to be rationalized and recalibrated. That may mean bringing some underfunded services up, but continuing to bring higher price services down to lower the system-wide average commercial price. We are striving for a simple yet predictable approach to reference-based pricing. We intend to use the Medicare adjusted base rate to reduce variation from Medicare specific adjustments and to improve comparability across hospitals. As we mentioned, critical access hospitals are reimbursed entirely differently than PPS hospitals. So there needs to be a methodology that translates critical access hospital commercial payments to similar payments for PPS hospitals. And we will also need to develop, and we are working with our contractor on developing complementary approaches that could prevent revenue seeking or gaming behavior. We can think about our NPR caps, our net patient revenue caps, and the hospital budget review process in the short term, and then hospital building towards hospital global budgets in the long term. So with that, I will pass it over to our legal team, either Mike or Julia, whichever one of you are taking the next few slides.
Yeah, thank you very much, Kirk. I can take over here. So, hi everyone. My name is Julia Korlman. I'm a staff attorney with the Green Mountain Care Board, and I'm going to be going over a few of our statutory sections that outline some of the requirements for us during the rulemaking process. So first, we have Section 18 VSA 9375. This is one of the statutes in our Green Mountain Care Board subchapter, and it lists out some of the duties of the Green Mountain Care Board. There's a few different areas of this statute that mention reference-based pricing. Mainly, we have subsection 5, which lists setting rates for healthcare professionals, beginning with reference-based pricing as one of our duties. Additionally, we have subsection 1A. This section requires us to implement by rule methodologies for achieving payment reform and containing costs, and reference-based pricing is listed as one of these methodologies. And the statute calls out that this rulemaking would follow the rulemaking requirements of the Vermont Administrative Procedures Act, or VAPA. And then if we look into the statutes that are part of VAPA, we have Section 3 VSA 831A, and this section just reiterates for us that when a statute requires us to adopt rules, then we'll follow those requirements of VAPA. So if we turn here, this slide outlines some of the public engagement requirements under VAPA that we go through whenever we create a new rule. So the process starts with the Green Mountain Care Board determining through public hearings what language to include in the proposed rule. We then pre-file the rule with the Interagency Committee on Administrative Rules, or ICAR, and ICAR evaluates strategies for maximizing public input. The next step is filing a proposed rule with the Secretary of State's office. The proposed rule language will be posted online and in newspapers. We will then hold more public hearings to carefully consider any public comments. The next step is to file a final proposed rule with the Secretary of State's office and the Legislative Committee on Administrative Rules, or LCAR. Part of the LCAR filing includes an outline of public comments and our response to these comments. There's a review period for LCAR, and generally this period will include a public hearing with that committee. After meeting with LCAR, the last step is to file the adopted rule with the Secretary of State's office. So beyond VAPA, beyond these rulemaking requirements, there are 3 main other sections of statute that we will be looking at for additional requirements as we make the rule. So first, 18 VSA 9375B1 has additional requirements when implementing rules regarding methodologies for achieving payment reform and containing costs, which includes reference-based pricing under the statute. We have section 18 VSA 9375B5. This section describes reference-based pricing as a form of rate setting, and therefore the reference-based pricing rule will also be subject to general rate setting requirements contained in 18 VSA 9376. And then we also have 18 VSA 9376E, and that has specific requirements for establishing reference-based pricing. So from these sections, I've pulled out some of the specific requirements that will be part of the rulemaking process. So we'll work in collaboration with providers to preserve access to care and quality. We'll report our proposed rule to the House Committee on Healthcare and the Senate Committee on Health and Welfare. We'll engage Vermonters in seeking ways to equitably distribute health services. We'll take into consideration current Medicare designations and payment methodologies, encourage coordination and planning on a regional basis. We'll also work, oh, you can go to the next slide, please. Thanks. You can also, we'll also work to consult with health insurers, hospitals, and other healthcare professionals, the Office of the Healthcare Advocate, and the Agency of Human Services. We'll consider the composition of communities served by the hospital, as well as the hospital's role in Vermont's healthcare system. Ensure that healthcare professionals can't charge or collect from patients or health insurers any amount more than the reference-based price amount, and identify factors that would necessitate terminating or modifying the use of reference-based pricing for a hospital. So here we just have a slide showing a conceptual framework for the reference-based pricing rule. So the rule would include establishing a reference-based pricing methodology that's predictable and transparent for payers and providers, clearly define the scope of applicability and inclusion and exclusion criteria, ensure the process for determining, monitoring, and enforcing annual reference-based pricing caps is durable and integrates with existing regulatory processes like the hospital budget review, and it would allow for procedural flexibility to adjust the policy as the program matures. So here we have a chart that's showing the major steps in the rulemaking timeline. So before filing with the state, we'll work on drafting the rule language with multiple rounds of drafts and review. We'll solicit stakeholder feedback and present the rule to the Green Mountain Care Board members, and they will then vote to approve the rule for filing. We will then pre-file the rule with ICAR, and ICAR can have a hearing. And again, they look at making sure the public engagement is maximized. We'll then file with the Secretary of State's office, who posts the rule online and in newspapers. A public comment period opens up, and we'll have an additional 1 or more public hearings. After the public comment period closes, we'll file with LCAR, and LCAR can have a hearing on the rule as well. After approval from LCAR, we can file the rule with the Secretary of State's office, and then the effective date will be after that. And then I will turn it back over to the policy team. Thank you very much.
Great. Thank you, Julia. So we outlined a few questions for the board for you all to discuss. First, what other major components, if any, would you expect to see in this first iteration of the rule, knowing that we will likely refine and we could even expand the program and the rule as this program matures. So we could set floors for primary care or include professional services within the reference price cap. How are you thinking about a North Star and what is the right cadence or approach? We lay out a few options as we see them, but you may have others that you may want us to consider. Are we trying to get to the national average for commercial prices? Are we trying to get to the New England median or some other benchmark? Should we first focus on high price services or tackle certain categories of hospitals? And should there be annual or multi-year targets for aggregate savings or for resource reallocation? And then finally, how do you envision reference-based pricing intersecting with the hospital budget review process? And so we can either keep those questions up for you or we can take them down if that's easier. But Chair Foster, I will turn it back over to you to open it up for discussion.
I see you have 17 other slides. 17 other slides. Do you want to just, I think board members have some of these in their heads already. Do you want to finish the slides and then we can go to board members?
We can. We structured it so there could be a break, but I know we're running out of time. So I'm happy to finish out the presentation if that's best.
Yeah, let's do that. I think we can do that.
Okay. We'll keep going then. All right. Welcome back, everyone. For the second half of this presentation, we really want to introduce you all to our contractors who will be working with us on reference-based pricing analytic and implementation support, and to preview some of their upcoming work ahead, just so that folks are aware of the timeline. We issued a competitive request for proposal in December of 2025. Proposals were due at the end of January 2026. The competitive procurement process, it is lengthy and is deliberately lengthy and rigorous. It took 6 months from the issuance to the contract start date. We had 5 bidders submit incredible proposals. And we had several months of rigorously evaluating these submissions, meeting with the finalists, and then entering into contract negotiations with the selected finalists and securing all of the required approvals across state government. And just to reiterate, the contract was competitively awarded to Rand Corporation with Baylett Health as the subcontractor, and that contract did begin on July 1st, 2026. So next slide, please. This is just an overview of who Rand and Baylett are. They bring together both sides of this equation. One brings the economic rigor and the other brings the policy translation and implementation rigor. Rand is a nonprofit, nonpartisan, evidence-based public policy shop. They led the hospital price transparency studies, now entering into its 6th round. And that study was really foundational to states' understanding of their commercial prices relative to Medicare. We have historically participated in that study, and it does provide the methodological foundation for this work. Baylett Health is a boutique consulting firm. They have particular expertise in insurer and provider performance accountability, particularly at the state level, and they will be instrumental, and they have been instrumental in many states of establishing the reference-based pricing policy design. And so Rand and Baylett will actually be presenting at a board meeting in October to provide additional insight into their work. Next slide, please. So this just gives you a quick overview of how the project is organized from a leadership perspective. Rand is our prime contractor, which is led by Rachel Reed in coordination with Dan Cresbin as the co-PD. And then Baylett Health is a subcontractor, and the implementation lead for Baylett is Sarah Kinsler. Next slide, please. So there are 4 overarching project goals of this project to ensure a data-driven and evidence-based approach to our reference-based pricing program. The first, that we will develop a rigorous and transparent methodology for calculating prices as a percentage of Medicare. The second, that we will have detailed technical specifications for annual monitoring, enforcement, and compliance, and also methods for gaming detection. Another goal is to model the impacts on financial outcomes for hospitals, payers, and at the system level, as well as impacts on premiums and patient out-of-pocket spending. And then finally, a finished benchmarking methodology suitable for hospital budget guidance, and they will also provide technical input for our proposed rule. Next slide, please. The project is designed to be self-reinforcing across 3 primary domains: methodological development, enforcement and compliance and monitoring, and then financial impact analysis. So what we measure becomes what we model. Creating our monitoring and compliance approach will then feed into defining enforcement thresholds and refining our financial projections as we iterate on policy design in the run-up of filing the proposed rule. Next slide, please. So as we mentioned, Rand and Baylett will help develop a rigorous methodology for calculating commercial hospital prices as a percentage of Medicare, really using Rand's hospital price transparency study as the foundation. Among the outputs will be reproducible materials to ensure transparency across the system and smooth transition back to the GMCB team for long-term sustainability. And importantly, the project will identify opportunities for maintaining and improving quality alongside a data-driven methodology. So next slide, please. This slide provides a visual diagram of the framework for calculating the reference price and modeling the impacts by hospital. These are very early ideas, and we look forward to hospital and payer feedback on what will and what won't work so we can make this even stronger and more transparent. We know that hospitals in other states have done this, and they have done this well, and they often have done so under financial constraints. And we also know of examples from employers that have directly contracted with hospitals that pay either a fixed percentage of the Medicare expected payment or a cost plus payment, whichever is greater, but below that cap. As Olivia mentioned at the outset, we still envision hospitals and providers to negotiate below our reference-based pricing cap. And so this isn't just a cost-cutting exercise, and there are several reasons that we've already touched on why this is better for Vermonters. Next slide, please. This goes into greater detail about some of the components of developing the methodology. Again, right now, we are very focused on high-level process, and here you can see the various components that will underlie the methodology through which we can arrive at a reference price cap. Next slide, please. So then to focus on domain B, to ensure that Vermont's reference-based pricing program works as intended and achieves its objectives of rationalizing prices and lowering healthcare costs, Rand and Baylett will also develop a framework for enforcement, compliance, and monitoring. We will also be looking to integrate into existing regulatory processes, such as the hospital budget review process and insurer rate review. And really the purpose is to ensure transparency, that there is compliance from providers and payers with our payment rates, that we build a culture of continuous improvement, and that we protect the public interest. And there will be plenty of opportunities for stakeholder engagement throughout this process. Next slide, please. And then domain C, the financial impact analysis. This is another visual diagram of the key components that will go into that. We want to make healthcare more affordable for Vermonters, but we also want to develop financially sustainable pathways for Vermont's hospitals. While the GMCB, we are not responsible for hospital solvency, we can play a large role in setting the right cadence and getting closer to our peer states and to assisting hospitals in this process. And this really brings together both domains A and B. So under a variety of reference-based prices, we can also account for a variety of hospital behaviors or revenue-seeking behaviors. We can contemplate various operational decisions and arrive at caps that we feel comfortable with. Next slide, please. This gives you just an overview of the project timeline. This is very high level. We have structured a bulk of the work to happen on the front end. We have just completed the mobilization and foundation, and right now we are focused on the methodological development and the impact analysis and monitoring framework, which will take about 7 months from now. And that will eventually lead into the proposed rule. Next slide, please. So as you all have just seen, there's a lot of exciting and complex work ahead of us for Vermont's reference-based pricing program to get off the ground. We are really thrilled to be partnering with Rand and Baylett, and we know this program can't succeed without valuable input from our stakeholders and the Vermont public. As we continue to get this work underway, you can expect more frequent reference-based pricing project updates through our board meetings. Rand and Baylett will also hold designated stakeholder engagement sessions throughout the fall and winter to gather feedback on specific elements of Vermont's reference-based pricing program and methodology. Additionally, the board will be conducting a broader healthcare affordability tour. It's a work in progress this fall. Those are not being led by Rand and Baylett. It is more geared towards legislators, but there will be an opportunity for public input for those sessions as well. And it's another opportunity for us to hear directly from lawmakers. What are their hopes and dreams, and what are they hearing from the community relative to reference-based pricing? And then, as our legal team discussed, there will also be a formal public comment period for the proposed rule during the rule filing proceedings, and much more. So next slide, please. So looking ahead to some of the near-term next steps, GMCB will continue to have conversations with payers and providers to gauge their readiness to implement reference-based pricing, how we leverage the hospital budget review process, and to help stakeholders continue to prepare for reference-based pricing implementation. As we noted earlier, the next reference-based pricing board meeting will occur in October. Rand and Baylett will join us, and they'll focus on a strategic theory of change for reference-based pricing, where we were in yesteryear and here we are in the present, and where we intend to go under a new framework for having price caps. And this will also be accompanied by a complimentary presentation on increasing hospital efficiency in revenue-constrained environments by Baylett Health. So we can go to the next slide. And that's all we have for you today. I just want to reiterate, I know that the implementation process is quite complex. There's been a lot of work to date, even though it may not always feel like it. There's been a lot of work behind the scenes to get us in a place where we feel comfortable now updating everybody in public. And we are really excited for all of the work to come. The program, again, has not been implemented anywhere to date, although we do have analogs in other states where they have implemented reference-based pricing in individual markets where employers have directly contracted with hospitals. But Vermont, again, is the first state to do this commercial-wide for all hospitals with no exceptions. So I think, I'll pause there. Chair Foster, I'll turn it back over to you to open up for a discussion.
Thank you. I don't mind starting. I just have a couple bigger picture questions. So when we set our reference-based prices, are we considering how much money has been saved and thus we can take out through lowering prices due to the hospital and AHS's transformation work? That's one way we can think about this is, okay, we've reduced some inefficiencies, we've consolidated some services, we've taken those steps, and now we can reduce prices by X dollars. Or do we say Vermont hospitals need to be at a national or regional norm? This is the appropriate price. We set it, and then the system needs to change to accommodate that financial change. How should we be thinking about that?
I think that's a great observation. I think it's a bit of a mix of both. I think we have yet to see transformation. We've yet to see regionalization. I think we have heard of some promising efforts throughout this budget process, but we would need to see something material come about for there to really have been any revenue loss due to those efforts. And then I would also remind everybody that without utilization controls, there could still be profit maximization under this program. There could still be a world where revenues are high if we allow too many services to come up to the cap without reducing outlier services. So I think we have to be intentional and thoughtful about our design, and then also in how we are marrying this with transformation, like you said, Chair Foster. And I would also turn it over to Elena for any other thoughts you may have.
Yeah, no, I think that's great. I think I just want to make a plug for another stream of work we have on hospital efficiency and some learnings that we have there. And Kirk, you can remind me of the date I think we're planning for next couple months. But, in this work, we've been learning that a lot of hospitals that are able to operate under a Medicare reference-based price are those that, and do it efficiently and high quality, are those that have financial pressure to do so. So it's oftentimes you kind of need that incentive to kind of get going and look at yourself differently and facilitate that creative transformation that we need to see. So I think, we certainly don't want to move too fast that the system can't handle or absorb or pivot, but I think that we need to do this in tandem with transformation, or we may not see the transformation that we need to achieve those targets. So having that North Star and having a planned approach and giving hospitals, providers, and others time to pivot is going to be really important.
And then, as we take out money from the hospitals on their commercial prices, how does that intersect with obviously Medicaid reimbursements? Are we effectively trying to reverse cost shift through this? And how are we thinking and connecting with Medicaid on that?
Yeah, we have, and we've already had some preliminary conversations with our partners at DVHA, and I think that's an area we would like to continue to collaborate. Some of these services that we're seeing at risk are those that, we may need to come together with an aligned approach to the best of our ability and make sure that we're prioritizing necessarily in this work. So I think we have more to learn and to compare as we move forward, but, they have been willing partners to date, and I expect will continue to work with us as we move forward in this work.
And then I forget if you use like phase 2, but on an aggregate level to a certain level. And then the other option is going more granular and increasing certain service lines that you value and you want to protect and decreasing others. That can happen today with hospitals and insurance companies. Why isn't it, and what can we do to push them to do that? Because we're losing services, and we know that they're being claimed as underpaid, and we know that the hospitals and insurance companies have a lot of volition on where they've put those prices. Why do we need to do that when the industry and those executives and those boards have that responsibility and duty to their communities already? Why are we spending state money doing their job? That's their job.
I think that's more of a philosophical question, but I do think that, you know, they could do this, and we've asked them to do it for many years. I think Board Member Holmes, you have been, you know, talking about this since I got here in 2019, and it's 2026, and I haven't seen much progress on that front. So, you know, I think the reason why we're doing this is because we haven't seen the changes we've been asking for, you know, coming up on a decade plus. And, you know, I think that's a very fair question.
Okay. Given that, I would ask the policy team to help the board think about that issue and how we use our authorities in the budget process that we have coming up next week. This really should be happening. We all know it should be happening. I don't know if it's a panacea, but I think it should at least be pursued. I'd like you all to help us think about how to use our budgetary authorities to achieve that if it's not happening organically as it should be happening. Thank you. I think that's all I had. I appreciate the update. I want to wait and take in more information before I have any really other deep comments or questions, but thank you, and I'll open up to my colleagues on the board.
I could jump in. Appreciate the presentation and the work, and this isn't the kickoff, but this continued conversation and engagement on the topic. I do think that, I guess a question I have for you is, I mean, you asked us questions earlier, and I guess maybe part of those, a few of those questions I would turn around back to you, and I'm sorry for that, because these are some of the harder questions, but I guess my question is, are we able to get recommendations from places like RAND about how to think about what that right North Star kind of number is? It was mentioned earlier in the presentation that 275% of the Medicare base rate for those services. And I think that you said that we would get modeling of hospital revenue based upon these numbers. But I guess my question is, how are you all who kind of dig in and think through this every day, thinking about how we determine the right level of pricing, and what are the various factors that go into determining what is the right price point maximum for Vermont hospitals, and why?
I guess I can go first, Elaine. That's a great question, and part of why we have partnered with Rand and Baylett. You know, I'm not sure there is a perfect number. There are studies, and we heard, you know, back in January from Bob Murray, who discussed a body of literature which suggests that hospitals can return a profit and be financially viable in a world where they live below 200% of Medicare final payments. Where other states have gone in their programs has been 200% of Medicare final payments. If we were to adopt our approach, like I mentioned, that's 275% of the adjusted base rate. I think that brings us, if we were to get to 275%, I think that would get us more in line with where the country is going. I think more states are looking at reference-based pricing. Delaware just passed a very comprehensive law doing essentially what we're doing with glide paths, and also trying to get towards 200% of Medicare. So I think, you know, if we are thinking about trying to get back in line with where the country's going, I would think about doing 275% of the Medicare adjusted base rate. Now, where our hospitals are very, very high, and they are very high on outpatient services. And so we have to think about the mix of services at some of these hospitals, how we bring those down, and which services we allow to be brought up in a way that continues to allow hospitals to be financially viable without creating undue spending within the system. And we hope that RAND, and they certainly will be able to help us model that. I think the cadence is really an open question. You know, who do we start with, and who's first out the gate? Do we apply them to everybody? How quickly do we get to 275%? I think that is still an open question, but, you know, Elena and I, in our discussions, we've thought about, like in California, they have set a glide path for their high-priced hospitals over getting towards 2030 of progressively down in spending, going from 1.75% like down to 0.75% growth. So I think we can think about higher-priced hospitals on maybe a more accelerated track than those that maybe are financially distressed or maybe have lower payment levels as a starting place. But, you know, I don't want to say my biased opinion or my biased take, but I would say, drawing from the literature and what has worked in other states, I think a good goal would be to get to 275%. But Elena, I don't know if you have. Oh, go ahead.
Well, one thing that we often, sorry, Elena, go ahead.
I was just saying you did. That's great. I have nothing to add.
But I think one thing that we often talk about is, you know, what's uniquely Vermont when we're comparing against states. And I don't know if maybe states are the right, each state has a unique system or more of a national averages, regional averages. I'm not sure yet on that. I'd like to get some more data and understand that before making a decision in that process. But some of the things that come up often in the hospital budget process, and I know that there's variance across the country, are things like the provider tax, Medicaid reimbursements, dish payments, and those sorts of things. How do we, you know, and I guess this question comes to the role of, is it the commercial market that should offset losses from Medicaid, or should the broader state offset losses from Medicaid, or what are losses from Medicaid, and how much, you know, I guess the question is, how have you gotten advice, or do you have thoughts on how to think about the various other adjustments that individual particular hospitals may need based upon various factors like, say, payer mix, or how to think about our unique Vermont provider tax impact on hospital sustainability with regards to comparing against national benchmarks?
There are a couple things there, and provider taxes are coming down under the OBBA. So that's less coming out of hospitals, but less going to hospitals at the same time. When it comes to, Medicaid is a vitally important safety net program. They are keyed almost similarly to Medicare, but this is a state and federal partnership. There are federal dollars. And so when we talk about increasing payment rates for Medicaid, we would certainly want to have that discussion with DVHA, but there are federal partners at the table as well. And so when we talk about just increasing Medicaid rates, that impacts the state budget quite directly. And maybe that is a policy choice we want to make. And maybe that's what you're suggesting, that, you know, the state should be funding higher payments, but there are parameters to how high that those payments can go. Just federally, there are parameters there. So there's probably no world where you will see Medicaid paying 200% of Medicaid. And there are good justifications for that as well. But I think there are other areas where we could collaborate and think differently about payment approaches and how we do or structure, like maternity care and payment for labor and delivery services. And why are patients bypassing Vermont hospitals out of choice to go to Dartmouth or to go out of state for those services? If we want to keep them local, it may not always be price. We may need to think about revenue sharing with other hospitals if we want to keep these services at the hospitals like they are structured today. So there's that element, but I don't disagree with you that we need to be looking at Medicaid rates, but I don't think it's as simple as just telling them to increase. And I think there's more there to work through because it has very clear implications for the state budget at the same time that are probably more acute than are felt through the commercial market. And then I would also just add that when revenues increase, costs increase too. And we've seen that in the literature and we've seen that play out. And if we do not start pushing down on revenues, or if we don't acknowledge that there are limits to the system, then we will not see the system change. And that's somewhat what this program is about, is trying to find efficiencies, trying to improve margins, not just finding more places to increase prices, but to focus on services. What are the operating margins and can you make that positive? And how do we get there in a way that's not price gouging Vermonters and it's not draining the state budget? And I think that is a fundamental tension that we will feel as we develop this program. But I think that these are all considerations that we think about all the time that maybe are not so evident in the program or not so evident in public. But I think you're asking the right questions. And I think it really does inform the program design as well. And I don't know, Lena, if you have anything else to add.
No, but I think in thinking about what other levers there are available, we need to be really clear about some of the federal headwinds that are coming our way and the limits to what our Medicaid partners will be able to do to increase rates. So I think, we know this needs to happen, but I think it's not just going to be as easy as finding another revenue stream. I think that's why this transformation is really important and going to be essential to making sure this works well.
Thanks, Well, I mean, I think we could go on all day with these conversations, but let me pass on to other board members.
I have just two things I wanted to highlight.
Member TJ, if you don't mind, I'm going to interrupt just for 1 second because I think I got a note about the healthcare advocate schedule. So today's a day out of turn. So I'm going to turn to them because I think they have to run, if you don't mind. So Mr. Fisher.
Hi, can you hear me? My camera's off again. So thank you for the presentation and thank you for all the work and thank you for all the work that's yet to come. Appreciate it. I guess my one question is, and also thank you for the framing of continuing with S190. There is one piece of S190 I want to call your attention to and ask whether you considered it, and that is the language that, this goes very much to Dave Merman's questions just now, that reference-based pricing would be used to reduce prices incrementally until prices, until they are equal to national median prices by hospital type by 2030. Have you considered whether that language passed by the legislature, I don't know that it fits in a rule or where it fits exactly, but what are your thoughts about that?
Yes, we have considered it, and we posed it back to the board to see if that is still something that they are interested in, or if they are, rallying around that. It could go in the rule, Mike. The rule could specify a glide path down towards the national median by 2030 that we can contemplate getting there through how we set the cadence or how we implement reference-based pricing by hospital type or characteristic. But we have considered that. I think that was a great starting place. That certainly was not really a controversy when we were developing or in all of those negotiations. So while it wasn't codified, we would intend to put that in somewhere in this program so that we know where we're going and we can focus our efforts throughout this process.
Thank you very much. Thank you, Mr. Chair, for letting me bud the line, and thank you, board members.
Thank you. Sorry about that, Member TJ, but thanks for understanding. I'll turn to you.
No worries. So just to sort of go along with that same discussion, one of the first questions you had for us in those board slides was, should we be shooting for the New England median? I've also heard the number 275% of the base rate is maybe a national target. And then there's the national median hospital price by 2030. what I really want to add to that conversation is a discussion of affordability specific for Vermonters. So I don't know of those kind of different numbers, what's affordable. And then anything that's pegged to a hospital median, I don't know what our peers in other states will be doing, or if hospital prices will be increasing dramatically. But that's a concern if we're pegging it only to prices in other states. And then just to jump on with one other thought, I would like to be monitoring prices and spillover effects in other healthcare services that we will not be setting the prices for. So, and I realize you don't mean setting the prices, but setting a cap. So what will be happening in primary care? What will be happening in ambulatory surgical centers? I think we need to be monitoring the rest of the system to see what happens. And I think I'll be concerned about that. And then the other things that I think you've mentioned, but I don't know exactly how we will be monitoring them, are access, quality, and efficiency in our hospitals. So while we're doing this transformation and the AHS transformation, what are the impacts on those things, whether direct or not? So those were my kind of high level thoughts, and I will turn it over to others.
Any other board member thoughts at this moment? I know we'll be dealing with this for quite a while, and there's a lot to soak in.
I'll just say somewhat, some of these questions, I appreciate all this hard work. I really, really do. And I know so much is ongoing and will continue to ongo, and it's a work in progress, and it's incredibly innovative, and it's going to require titrating and really thinking about consequences. And as I think about this and I think about these questions, I think about what's the end state that we're really trying to achieve, for the whole system. This is why I think about things, Chair Foster's questions about Medicaid. How does that fit in? How does transformation fit in? There's so many things that have to be considered in this. What is the end state we're going towards? And when I think about that, what are the specific quality, cost, and access metrics we would hope to achieve or see the system achieve in the short term, medium term, and long term? And then I guess I would say, what part does reference-based pricing pay in getting us there? Before I could really answer these questions, and I think they're great questions, I think I would love to see modeling, right? Modeling that's done of like, okay, this is the end state we want to see on all of these, on the AAA and quality, cost, and access. And how would different reference-based pricing approaches, the speed, the type, what we target, help us get there? And what are the, how do different methodologies impact the speed or the achievement of that end state? And I am worried about unintended consequences, right? That's always something that we have to worry about. So we decrease price here. How does that impact affordability and we know it'll impact affordability potentially, but how does it impact access and quality? I feel like that needs to be modeled, and I'm hoping that that's what RAND and Bailet can offer, is these different methodologies will help you achieve that end state, but there's intended consequences, but there's unintended consequences that are also being factored in and measured. And to me, it's really hard to answer these questions without more modeling and understanding of how different methodologies and different approaches will help us get to an end state that's not just about affordability, but it's also about access and quality, because obviously those things all work together. So I really appreciate this, and it's given me a lot of things to think about, but I think it would be wonderful to have RAND and Bailet come in and give us some of their thoughts to some of other, I think, Member Merman's questions as well, of thinking about the recommendations and the modeling. So that's where I, am feeling in this moment is I need more information and an understanding of the consequences and unintended and intended of some of this. So that's it from me.
Right, I'll jump in quick. Just a couple questions after listening to the presentation and to other board members. What really struck me through this is that reference-based pricing by itself will not create an affordable healthcare system. There are other aspects that are left untouched. We think of putting a cap on price, there's still utilization. Overall revenue, the piece that actually ends up trickling into affordability. There's price, there's utilization. We think of price times utilization. But that equation is broader. It actually includes subtracting operating expense. Price times utilization, subtract operating expense. So a couple questions that I hope the contractors will help us with. If we are successful in restraining revenue, to get to real affordability will require that hospitals reduce their operating expense. How will we know when a hospital tells us they need more expense or more revenue? How will we be able to determine whether that's a genuine need or whether there's just excess expense still in the system? I think right now that's a judgment that could use some more detail. And I think if this push toward lowering prices, lowering revenue, more affordability, we also have an access problem, and it's not completely clear how much that is actually pent-up need. But if prices do come down, affordability improves. You could imagine a scenario where then more people go to the doctor and utilization would rise. And so I'm looking for help in understanding volume changes, the difference between better access to needed care and unnecessary utilization, or gained utilization, as you were saying. So those are two areas: better understanding operating expense management and better understanding utilization of services. So thank you.
Great. Thank you so much. And thank you, Member Holmes and Member Walsh, for we can definitely take those back to our contractors. And I think these are all things that we are thinking about, but we are still in the early stages of standing this project up. So that's very helpful. Again, in our October meeting, Rand and Baylett will be here. They will be presenting on the strategic theory of change. Member Holmes, your questions about like, where are we going? What is the end state? What are the metrics we should be looking at? We intend for that to be part of that discussion. So this is really helpful for us to bring back to the group to talk about. And then I would also say, there could be unintended consequences. There are plenty of unintended consequences right now under the status quo. So I think it's how do we manage or transition into a different type of world? And I think we're being very thoughtful. And I think this is another reminder that right now the prices are very unaffordable, and that is not lost on us. We also know that go too low, utilization can get really, really high, or we know that we may risk losing hospitals. And some of that, we don't want it to be just due to these price effects. So I think you've given us a lot to chew on and a lot for us to think about. And I think this is the tension that often we wrestle with as staff when we're trying to come up with recommendations for you all of where to go. But I really do appreciate all of these questions. And I think it's really instructive for how we're informing the modeling going forward. And so you will see a lot of these questions reflected back as answers in future sessions. So I really do appreciate it.
Thank you. And I'll open it up to public comment via raise the hand. Chair Black.
Hi, thank you. Really, really great presentation. I will just say, you do bills and you have ideas in your heads, and you allocate resources, and very often I look and think, well, that was a waste. I'm not thinking that. It absolutely iterates for me personally why, it was clear that that this was work that the Green Mountain Care Board was best poised to do. and your enthusiasm for it, and both you and Elena and everybody who's working on this. It shows. I appreciate just how deeply thoughtful you are. You're going through your slides, and I'm like, gosh, I didn't think about that question. So, I talk about, we keep using metaphors today, and talk about a roadmap. You are developing a roadmap, and I'm sorry the rulemaking process took so long. Anyways, just deep appreciation. I did, but the healthcare advocate, of course, stole my thunder in part of S190. One thing that we learned in 2026 was that we actually forgot in Act 68 to define where we're going. And we did set a benchmark of 50%. So I hope that, you can think about legislative intent, even though it was vetoed. That's kind of where we're going. But more than anything, some of the questions from Member Holmes and Merman and Walsh, I personally have been thinking a lot about lately, kind of, when you set a goal for something, you work towards that goal, and that becomes where your driving force is. And I fear that if we use reference-based pricing and we say our goal is to say get us to the 50th percentile of the rest of the nation, at least in line. I fear if we set that as the goal, then that will drive what we're trying to achieve. And I've come to, over the last year, since Act 68 passed, I think I'm asking different questions this year than I was when we passed that bill. And it's, I am not thinking of reference-based pricing as this panacea of saving the system money and getting us to a place of affordability or even quality or even accessibility. What I see reference-based pricing as is aligning, as you all know just as well as I know, that there is absolutely no relation whatsoever to the price that we pay for something and what we value something as. There's in healthcare, there is no relation beyond that. And what I'm thinking now of reference-based pricing is this gives us an enormous opportunity. And other states who have done reference-based pricing haven't looked at it this way. It allows us to actually change the payment system to pay for the things we value. And I really firmly believe that if we keep that as the goal of reference-based pricing, to realign our values, to reallocate our resources to what we say we value and what Vermonters value, I think all those other things will follow. I think quality will follow. I think that accessibility will follow. I think that affordability will follow. But I think that the goal should be using reference-based pricing to pay for the things that we value. And I think all those other things will follow along with it. I think we've learned from all of our other failed experiments in healthcare that when we focus on this will save costs or this will do this or that, they ultimately always fail. Because we haven't asked the question of maybe we just pay for things that we care about. Anyways, thank you. I did want to make the point, because I know that several insurance companies are on here, and I appreciate Chair Foster mentioning this, but S190 may have been vetoed, a bill that was long, hard work amongst everyone, to include the administration, a bill that would have saved Vermonters millions and millions of dollars in the highest stressed insurance markets. People think all insurance markets are not the same. They are not starting from the same point. But despite that, and despite that veto, and despite your rulemaking process, insurance companies have the ability right now, they have always had that ability to negotiate better. Reference-based pricing is coming. You might as well get a jump start on it. Start negotiating. That was all. Thank you.
Or better, do it yourself so we don't have to. I mean, my view is honestly that if the regulator does it, it's the last, you don't want that to happen. We're not as in the weeds and as smart as industry. So, I mean, the truth is we're the backstop, but it should really happen without us.
How about starting reference-based pricing in the QHP market? You could do that today.
I agree with that sentiment. Thank you, Chair Black. Walter?
Thanks, Owen. The board and Chair Black had pretty much said what I wanted to say, and I just wanted to say that Kirk has also said the unmentionable when he said price gouging. And that is the undercurrent of the entire system that is going on. And we need to acknowledge that. It is price gouging.
Thank you, Walter. And I think if slide 15, I think was really demonstrated that I think quite well. Those are really, really, really inequitable prices. And that is part of our charge at the board is to make sure financing is equitable. And it's hard for me as a board member to see 600, 800, 1,000% of Medicare on patients that receive that service as an equitable or sustainable way to finance a health system, which goes to my broader point that this needs to be addressed by the insurers and the hospitals today because it is not equitable. Ms. Ridson?
Hi, can you hear me?
Yes.
Hi, for those who don't know me, I'm Susan Ridson with Health First Independent Practice Association. Really appreciate all the work and discussion, very interesting. I'm just wondering, this is along the lines of unintended consequences, how is the team thinking about the rule language, how it might impact independent and non-hospital providers? For example, the language around healthcare professionals not being able to charge above the cap could subject independents to the yet undefined floor when the professional fee schedule that independents are subject to is already lower compared to the hospital outpatient department fee schedule. This could widen existing reimbursement disparities, and I would suggest being intentional and closing that gap for outpatient services that can be safely delivered outside of hospitals, such as those services identified by MedPAC.
Thank you, Susan.
Comment.
Oh, yeah, I was just going to say thank you for your comment. I think for the professional services, we're seeing that as kind of a step two and not kind of going there in this first round. But certainly, you know, our target for this initial rule, the applicability is really around hospitals and hospital facilities. So focusing on the IPPS and OPPS services. But I think as we move forward, making sure that we're not inadvertently including services or providers that shouldn't be part of that will be important as we move forward. So thank you for your comments.
Yeah, and I do understand that the hospitals are the first. I just want to make sure there's no rule language that will unintentionally, you know, hamstring.
Yes.
Yeah.
And we will publish the rule of various drafts as we move forward, and there will be opportunity to triple check us, but our legal team is all over it. Thank you.
Thank you.
Thanks, Ms. Ridson, and nice to see you. Senator Hardy?
Oh, am I unmuted now?
Yep, we can hear you.
Okay, thank you. Thank you. I can't undo my camera, so sorry about that. But thank you. I missed some of what Representative Black said because I had computer issues, but I did just want to comment on both what Rep. Black said and Chair Foster said about the market being able to do this on their own right now, the insurance companies and the hospitals. And you're absolutely right. And we've had insurance companies under a lot of financial stress, hospitals under a lot of financial stress, and we've had at least one hospital that has been an unwilling partner in all of this. And so what happens when the market won't do it is that government has to do it and the regulator has to do it, especially in a situation where we have a monopoly, which was one of the first slides that Kirk, I believe, presented, was essentially the monopoly situation we have here. So yes, I definitely want to and encourage the market to do what they should do. But in that absence, that's our job and your job. And I would contend that you are smarter than they are. I've seen your work. I know your work. I know all of you. You're smarter. And you have great staff to work with you. So just wanted to say that. But also, I had a question about the timeline. And because S190 was vetoed, and that was basically the legislature telling you our legislative intent of where we wanted you to start, and that was vetoed. And I believe that the first year that this was supposed to go into effect was FY27. This is FY27. And in your presentation, it seemed to me that there were a lot of questions from staff to the board and to the sort of universe of where should we start? Should we start with the services should we start with services? Should we start with hospitals? Should we start with markets? Where should we start? So I guess my question is, given that we're in FY27, given that the legislative intent of where we wanted you to start has been vetoed, where are you starting, and when can we expect the at least initial the initial start of all of this project before us?
Yeah, good question, Senator Hardy, and thank you for the compliment towards our wonderful staff and my colleagues on the board. They are obviously exceptional and top notch, and that's how you get to take on this work. So we appreciate you recognizing that. It's something we get to live every day. In terms of the timing, yes, there was aspects of S190 that we very much supported. We supported the bill, and a lot of that was to help us be able to implement this in FY27 and to deal with some of the rulemaking requirements. There are some temporal aspects to rolling this out that are complicated in sequencing that made this trickier, especially with S190's change. And that was really hospital budget guidance is due in March. And so there's like a lack of clarity of where some of the changes were going in the legislature before we did guidance. One of the things we did do, and it kind of depends on how you define and think about reference-based pricing, there are many ways to do it. And I think the staff did a good job walking us through how granular you can do it, or you can do it at a high level. And what we have been doing at the board, in my mind, actually is reference-based pricing. If you look at our hospital budget process the last 3 years, really, we've been looking at high-priced hospitals and either giving them lower rate increases or, frankly, significantly decreasing their prices. So UVM's prices, for example, I don't have the number right in my head, but it's around 10-12% the last couple of years that their prices have gone down. And so their prices are more in line nationally today than they were 2-3 years ago by quite a bit. And then the budget guidance process here, we had a guidance of -1% prices. Again, if you compare that towards national increases in hospital prices, even our QHP plans that we just reviewed their filings, we saw out-of-state hospitals going up a lot more than that. And in-state, we're going down 1%. And that's something you'll see across the entire country. So we are, in many ways, getting our prices more in line already. And then the work that the staff discussed is really the next iteration of doing it more thoroughly, more granularly, and smarter. It is an iterative process. This is extremely complex. And I think Member Holmes and the other board members highlighted all the concerns you have, which is why you do this. You roll it out the way we are. You have the extensive stakeholder engagement process, and we'll go through the rulemaking process to make sure that we avoid some of those pitfalls. But in the meantime, we are helping Vermont insurance rates and Vermonters afford healthcare a lot by reducing their prices. And that's why we've seen this year and last year some of the best, lowest commercial insurance rate increases in the country. I'm not one to say that we're where we need to be. I do recognize, and it is clearly not affordable. I would like to have gone negative if we could. That would be great. But balancing all of our other competing interests, I think we should be happy that the team that we have has reduced prices to a level that has allowed us to at least achieve a big move towards getting back in line on our commercial insurance rates. And just if you'll indulge me for one more second, our commercial insurance rates, I hate when people say it's complicated because people pay. No one paying cares if it's complicated. They care what they're paying. But there are differences in the Vermont market and some of the available products in our insurance market that makes our QHP quite a bit more expensive. And when you look at the QHP prices, they're looking at the price for a 40-year-old. And for a 40-year-old, our prices are very high. Whereas the prices for an elderly person, they're actually not as bad. So there's some apples to apples stuff going on there that we also need to just, I think, be cognizant of. We don't want to reduce prices in a way that really does hamstring people's ability to get care, which is why we have this extensive process and the team that we have to do it. So thank you for the question, and I hope that gave a high-level response from my vantage point.
Sure, yes, that's helpful. Thank you.
Okay, great. Thank you. Any other public comment? Okay, thank you very much, Kirk and Elena. Is there any old or new business for the board? And then I move that we adjourn.
Second.
All in favor, say aye.
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 Aye. We're adjourned. Everyone have a nice day.